This is going to cover the assessment of the trauma patient. So once you arrive on a scene of a traumatic injury, a huge priority of yours needs to be consideration of manually stabilizing the cervical spine, or more commonly known as the C-spine. So as you come up, the very first thing you should do whenever you're touching that patient, you're focusing on airway, breathing, circulation, or your CABs, depending on if the patient's alert or unresponsive. But before you do anything else, you need to manually stabilize that cervical spine. That's a big priority. So before you're going up, putting your hand on their chest, assessing them for breathing, first thing you touch on that patient is holding that cervical spine. So when you're assessing that trauma patient, there's a few factors to be considering to determine how serious that patient's injuries may be. Considering the mechanism of injury. How did they get hurt? Was it a major traumatic injury or something more subtle such as a splinter? Assessing their mental status. If any patient has an altered mental status, that is a very significant indicator of a serious injury. Any altered mental status in a patient, serious sign of significant injury. With the patient's airway, is it patent? Are they able to breathe well? Do they have substances such as blood or mud or teeth, something in their mouth, something that's going to mess up their whole airway, take away the big function? Then within your secondary assessment, those vital signs, taking into consideration what their normal vital signs may be, or you might go to a patient and everything seems okay, and then once you start assessing them, you realize that they're hypotensive, they're tachycardic, they're bordering on decompensated shock. Their vital signs indicate that the patient is significantly injured. And then also predisposing factors such as the patient's age, their previous medical history. Pediatrics can compensate a little bit longer, more so than adults, whereas the geriatric population may be hurt more than they may realize. While you're conducting that physical exam on that trauma patient, there are 3 techniques that you use: observation, palpation, and auscultation. So the key is you look before you touch. So you look at it, see if you see anything crazy, touch it to be feeling if you feel anything crazy, and then in the thoracic cavity or checking that out, you auscultate lung sounds quickly. So you're checking for abnormalities in symmetry. Does anything have a bend in it that's not supposed to? Checking their collar. With your A, B's, and your C's, when you're checking for circulation, you're checking skin, color, temperature, condition. Seeing if it's pink, if it's pale, if it's red. So when you're checking for that collar, you're checking everywhere. Does the right leg have the same collar as the left leg? And then checking the shapes. Is it swollen? Is it deformed? Are they able to move all their appendages? Does anything just look like it shouldn't? So when you palpate, after you've looked, now you're palpating. So now you're actually feeling, checking for everything. So now you're checking for those abnormalities in shape. So as you feel around the arms, the chest, the legs, are there any bumps where there shouldn't be bumps? You're checking that temperature, the skin color, temperature, condition. Remember, so you're checking to see if they're warm, if they're cold, if they're sticky and clammy. And when you're touching them, are they able to feel that? So when you do ask if they are able to sense something, ask them if they know what you're touching. So if you're feeling around the right foot, say, can you feel this? And if they say yes, say, okay, what am I touching? Because if you say, do you feel this? They don't know maybe exactly what you're referring to. They might think that the pain that they're feeling might be you poking them, checking something out. So always ask if the patient knows what you are touching. So a big component of that mnemonic is decap BTLS. So you're checking for deformities. Anything that doesn't look like it's supposed to. Bends or bumps where there are not supposed to be any. Contusions. Contusions is a bruise. Abrasions, any road rashes, any just scraping or skin tears. Punctures and penetrations. Is there any holes where there should not be any holes? Is there any burns? Is there any tenderness when you're palpating? Does it hurt when you touch them? Any lacerations? Any cuts? Is there any swelling? So you've looked and you've touched, and now you're going to listen. So you listen mid-clavicular on that thoracic cavity, checking for any decreased or absent breath sounds. So all we're doing is just quick listens on the thoracic cavity to make sure that there's not any issues, possibly a pneumothorax, tension pneumothorax, anything like that. Because at this point, we're trying to do down and dirty quick stuff, because at this, we're not want to auscultate all the fields, because that's what we do on medical patients. And this, we're trying to make sure that they didn't damage their lungs in any way. Some general principles that apply to performing a trauma assessment is you need to communicate with that patient. Just don't go blindly looking and poking and touch on the patient. Let them know what you're going to be doing, keeping that open line of communication with them. Also with that, as you're going down examining the legs, you're not looking up at their airway. So if you continue to talk to them, making them say yes, no, answer questions, you're also determining, making sure the airway is still patent while you're not looking at them. You need to expose any injured area before you examine it. Just think how bad it would hurt if you just start randomly grabbing on the leg and they've got on long pants. But when you go and grab that leg, you didn't expose it, and there's actually a bone protruding through the skin that you just went and grabbed. So those big painful things that are majorly deformed, it probably hurts, and there's probably going to be tenderness that's assumed, so you don't have to grab and poke on it. So the big rule of thumb, all trauma patients get trauma naked. You get all of them butt naked so you can check out and see everything. You need to maintain eye contact with them. So doing this, you're helping to assess their mental status too, making sure they're not going unresponsive, be talking to them. Always and continual maintain that manual cervical spine. Hold on to it throughout the entire assessment. That's a huge priority, because if you have any kind of damage to that cervical spine and you're not treating it accordingly, you're going to make the patient paralyzed. So always hold on to that cervical spine the whole time. So, and you're thinking, well, how am I supposed to hold the cervical spine while I'm checking out their legs? So if you didn't get that point, somebody else, it is their sole job to maintain that cervical spine. That's all they do. So they could be their job to be talking to them, checking the airway, holding the C-spine, looking at their eyes, keeping them alert and awake. And always, worst case scenario, assume spinal injury. If a patient's unresponsive just laying on the ground, assume worst case scenario that the patient is unresponsive due to a traumatic injury, unless you could be definitive otherwise. If you find anything that is life-threatening during that assessment, you need to intervene and control that before you go on. Say if you go up to the patient and they've got blood squirting out of their forearm, you need to stop that bleeding before you go and start assessing other things. So always treat life threats as you find them. If anything else you find is abnormal, just note it and go on. So if you're going down the leg and it seems like their femur's bent, note it and go on, finish your assessment. And always, always, always look before you touch, so you don't damage or further injure that patient. Now, the way you initially perform an assessment is called a rapid trauma assessment. This only takes a few minutes. You're working from head to toe, doing your DCAT BTLS, looking, listening, feeling, checking everything out on the body, just real quick, down and dirty, trying to find those big things that might stick out. So any kind of care you're going to provide en route is pretty much going to be based on this rapid trauma assessment. But when you do those assessments, it's not one and done. You're just trying to find the big stuff, paint the big picture of what's going on with your patient. So as I said, you start at the head. You're palpating the head, the face, the ears, looking at the eyes, looking at the nose, and looking at the mouth. That doesn't mean you got to take out your pen light and shove up the nose and be checking out anything in there, shoving it in the mouth, looking around there. You're just taking a good, quick observation of all those areas. So palpate the face and the head, looking around, a 360-degree view and full assessment of that head. If you find any blood or clear fluid coming out, that's a serious finding. So any clear fluid coming out of the ears or the nose is probably cerebral spinal fluid. That means that part of their skull is broke and the fluid that should be around their brain is now running down their neck. Very serious finding. But if you find it, note it, and go on. As you go on, after you've done the head, you looked at the face, the ears, the eyes, the nose, and the mouth. Then you're going down to the neck. So again, 360 degrees. So you're feeling the back of the neck, feeling the spine, every step of it, seeing if there's any tenderness, any deformities, any stepping to that cervical vertebrae. And then you're checking the front side of it, the anterior side, checking to make sure there's no JVD, that there's no tracheal deviation, looking right at the median notch, right between the collarbones. Make sure that trach is right midline as it should be. Now note, if a patient is laying supine, as we're generally going to always be doing in a rapid trauma assessment, finding JVD is not always a big indicator. Most patients, as they lay down on their back, they have JVD. If you see it, note it, and go on. So as you see in the picture, palpating the head with a gloved hand, you have to feel the entire thing using all 5 fingers, assuming you have 5 fingers on each hand, and using the ball of your hands, feeling everything, checking that decap BTLS. As you go through the hair, if patients have long, dark hair, keep it on your gloves to make sure as you run through the head, you may not feel anything, but as your gloves come back out, you may have blood on your gloves. Note it and go on, unless it's severely life-threatening, which generally head bleeds on the outside or not. After you have checked the neck, you may apply a cervical collar, putting on that C collar, but you must check it before you apply it. You can't put a C collar on and then assess their cervical vertebrae with the C collar in place. So look, touch everything on the neck before you cover it up. If there's anything going to get in the way of that cervical spine, you need to remove it, such as jewelry. Pull the hair out of the way. Don't cut it off. They'll get mad. If there's any hoods, you may have to cut the hoods out of the way, which they're going to be getting naked anyways, unless it's a simple thing where it's just neck pain and neck pain only. Then maybe the clothes could stay on. But if there's a hood in the way, cut it off. Keep their head in the anatomical position. Make sure that you don't put the C-collar on because they want to look to the left. Put their head in the way it's supposed to be. So you'll put the C-collar in place from the front while somebody's still manually holding the head. You'll wrap it around and Velcro it on. Once you've applied the C-collar, that alone does not provide enough inline immobilization. So it just helps. So as you put the C-collar on, manual cervical spine still has to be maintained. So even though C-collar's on, somebody's still up there holding the head in place at all times. The most full method is once they're in a C-collar and they're on the backboard, that it's manually fixed and strapped to that board. So as the C-collar goes on, blocks go around the C-collar and hold everything in place. After you finish your assessment of the neck, now you're going down to the thoracic cavity and the chest. So again, you look before you touch. So look to make sure you have equal rise and fall out of the chest. Make sure there's no paradoxical motion. Making sure that everything goes according as it should. That the chest coming up doesn't look like a teeter-totter. That one side goes up, the other side goes in. That's bad. So looking at that, because you don't want to go and just start poking a bunch of broken ribs on an already very injured patient. So checking for the motion. Now you can go and touch. So after you see the chest comes up, everything seems to be okay, then you feel. So you'll be checking for any kind of crepitation. Again, all the decap BTLS. So you'll feel on the chest, push on the sternum, squeeze on the ribs. You'll push on the sternum and squeeze on the ribs. And then you're going to listen for breath sounds. So mid-clavicular on both sides, just below the collarbone, and then listen mid-axillary, checking for breath sounds. You just want to make sure you hear them and they seem to be the same bilaterally. So as you're assessing the chest, you're pushing on the sternum and squeezing on the ribs. Then you're auscultating mid-clavicular line. Then you go on to assess the abdomen. So again, you look before you touch it. Make sure you don't see anything pulsating in it. It could be an aneurysm or something. The last thing you want to do is have a large pulse in the belly. Then you go and touch it, and their vessels explode on the inside. That's bad. So gently press on the quadrants. If a patient tells you initially that one area of their abdomen hurts, that is the area you will assess last. Assess the painful area last. So you'll gently press down on all the quadrants, checking for any kind of distension. See if the belly sticks out. Is it hard? Is it rigid? Do you find any masses? Anything abnormal in the belly? And remember, we're treating sometimes a large bariatric population, so that distension of the belly might just be due to Budweiser, not a traumatic injury. Then you go into the pelvis. Look before you touch it. So at the pelvis, we are checking for the pelvis, the pulse, and the penis. Okay. So in the pelvis, you're checking those pulses, and then you're going to be checking for priapism. If a male patient has an erection, that is a significant indicator of spinal trauma. It doesn't mean that they're thoroughly enjoying the trauma assessment. It means they are really hurt. So you check pelvis, pulse, and penis. So in the pelvis, you'll push on it and you'll squeeze on it. Then you check for pulses on the hip bone, right in the groin, and then you just sweep down, checking for priapism. If you don't have them quite naked at this point, if they're still in their underwear, it doesn't mean you gotta lift it up and look. You should be able to just do a quick swipe down and feel it. Then you're going on to the lower extremities, checking decap BTLS. So you'll go down one leg at a time, squeezing and feeling all the way down from the hip to the ankle. Then you'll do the next leg, hip to the ankle. And then you assess the feet at the same time, because you're checking the circulation, motor, and sensation of both feet. So you'll check pulses. Then you're going to check motor. Can they wiggle? Can they feel? If they can't, tickle the bottom of their foot. If they're not obeying any commands, to see if they kind of have some ticklish tootsies. Make sure their toes can curl. And the Babinski reflex, as you tickle their foot, all the toes should curl down in anybody over about the age of 2. If their big toe goes up and the little toes go down, that's a very, very bad sign of a traumatic injury. And then checking sensation. See if they can feel it, if they're able to obey commands. And remember, touch a left foot, ask, what am I touching? Hopefully they're going to say the left foot. So with that sensation, if they can't feel it because they're unresponsive, when you tickle their foot and the toes curl, that'll be an indicator of sensation. So checking that CMS of those lower extremities, checking the pulse behind the ankle bone, the tibial pulse, or you can check the dorsalis pulse on the top of the foot. These pulses are hard to find, so if you find them, take out a Sharpie or a pen, put a little mark on their foot, because you're going to have to continue to assess their CMS throughout. So put a pin mark on it so you know where to find it again quickly the next time. After you've done the lower extremities, you go up and you touch and you feel the upper extremities too. One arm at a time, then do the other arm, then check CMS in both at the same time. So you'll check pulses at the same time using both hands. Grab both their radial pulses. Make sure they're present and they're equal. Then to check motor and sensory, have them grab your fingers, checking the strength. After you've done that, it's time to move on to the back side. So you're going to want to roll the patient onto their least injured side. So if they've really busted up their right arm, put them on the left side. If the right arm's really busted up and the left arm's a little busted up, you still have to roll them on the side. And just forewarn them that it's probably going to hurt. So as you roll them on the side, the patient at the head is in charge. They're still holding the cervical spine, and they will do the counting to roll on their count. So as a patient gets rolled up on the side, with generally 2 people have to roll the patient. The 2 people standing or kneeled at the side will have their arms crossed. grabbing a shoulder, 2 hands in the hip area, cross there, then another one down to lower extremities. Roll that patient onto the least injured side, and then one person is going to check the spine, going from up as far as you can reach, from the C-collar or wherever you're holding manual stabilization, all the way from the neck down to the tailbone. As you get down to the tailbone, which the tailbone runs into the butt crack, so you got to get up in her business a little bit. And then you're checking for bright red butt blood. Any kind of butt blood in a traumatic patient is bad. They're bleeding out their butt. That's bad. They've damaged their internal organs. But note it and go on. So as you have the patient roll on their side, as soon as they roll back, you need to always roll a patient onto a backboard. Always roll your patient back onto a backboard. So a picture here of assessing the spine. You will walk your fingertips down every single vertebrae of that back. Don't just go and skip them because you're looking for any kind of abnormalities, any stepping, any vertebrae that feel a little out of whack, all the way from the spine, all the way down to their butt crack. So then once they get onto the board, this is how they should look. They're on the board. You see the C-collar in place. You see the head blocks over, creating the full cervical immobilization, and then straps down over the body. Try to avoid putting straps over the abdomen, and be careful on the chest so that they can breathe. So as you put a strap across the chest, ask them to take a deep breath so that chest cavity is as big as it needs to be to breathe, and then strap down as they're taking a deep breath. The lower straps, try to avoid any injury sites, but try to get all the way down to the ankles depending on how big your straps are and how big the patient is. And then you can leave the arms freed out if they're responsive and they can put their arms up, put them on their belly, or if need to, you can strap those arms in as well. But it's good to have the arms freed so you can assess vital signs. Now with pediatrics, it takes a lot less of a mechanism of injury to cause significant damage. So those little kids, they take, a small fall can cause quite a bit of damage to them. You need to explain your assessment to them very thoroughly too, because they don't know what's going on. They're probably hurt, they're freaking out. You need to try to keep them calm and relaxed. After you've got the patient immobilized, then you're going into your secondary assessment of getting your vital signs and past medical history. So after your full physical exam, your rapid trauma assessment, then you're checking your vital signs. Then you're doing your sample, your OPQRST, trying to get the patient's background information. So after you have your patient fully immobilized and you're on the way down the road, and you've done your past medical history, you've got your sample, OPQRST, and your good first set of vital signs, then you're going into your detailed physical exam. Now, this doesn't mean it can always get done. Sometimes you may not be able to get past the A, B's, and C's, or that life-threatening bleeding, or a short transport to the hospital to be able to do a secondary assessment. Or sometimes you may not even be able to get to a full trauma assessment because you're so worried about those A, B's, and C's. So with that detailed physical exam, it's a lot more thorough than that rapid trauma assessment. It's going to be identical to the trauma assessment, just much more in-depth. So this is where at the head you can spend a little bit more time taking that pen light, looking in the nose, looking in the mouth, checking their pupils, see if the pupils are equal, round, or reactive to light. And going more methodically all the way through the body, so not rushing through it, listening to lung sounds again, maybe a little bit more thorough, spend a little bit more time checking the CMS again, always. That is something after every immobilization you have to reassess CMS. You always reassess the CMS because you're doing this because you may have missed something in that rapid trauma assessment. You're going so fast you miss something, or something may have changed. Once they got immobilized, they might be crashing. Their vital signs are going down and they're starting to lose those pedal pulses or their radial pulses. Keep an eye on that. Always, always, always reassess if your patient's condition will allow. Now, if you have a patient that's not seriously injured, they've just got, an isolated injury that somebody shut their finger in a car door and they broke their finger. Yes, they are a trauma patient, but that doesn't mean you need to mandate them to lay on the ground, cut all their clothes off, stick them on a board, and butt naked in front of everybody and rush them to the hospital. Use some common sense of what will be a serious injury, and your gut instinct will generally give that away. Somebody who's been in a very serious car accident or somebody who took a very significant fall, that big mechanism of injury or the signs and symptoms or how the patient presents of how injured they may be is when you're going to do your full thorough trauma workup. But for isolated injuries, sprains, pains, simple dislocations or broken bones, use some common sense and just treat them accordingly with passion.